more sustainable healthcare system. This event reflects our commitment to sharing ideas and driving innovation in our region and beyond. We hope today's discussion inspires new ways of thinking and strengthens the partnerships needed to advance meaningful change. Thank you for being here, especially for those attending in person at our Baltimore office. I'll now turn it over to Zach Rabovsky, our Director of Population Health, to begin the panel discussion.
Excellent. Thank you, Tina. Welcome, everyone. I'm Zach Rabovsky. I lead our practice transformation team, and I've been here at CareFirst for almost 12 years supporting value-based care, working with our providers and our health systems in value-based care models. And I'm really excited to be hosting this panel discussion today and diving into the value of value-based care. We'll double down on value. It's really a great opportunity for us to talk about the evolution of healthcare in this country and what we're doing to address the rising costs of care. And when we think about both of those, the importance of finding value-based care initiatives that focus on quality and affordability is paramount right now. And when we effectively implement these different models, we can foster innovation, we can improve the patient experience, and overall improve health and wellness of our populations, our communities, and our individuals here. At CareFirst, we've been doing this a while. Our PCMH program in its 15th year was our original value-based program, putting PCPs at the center of the healthcare journey, allowing our providers to quarterback the care and manage total cost of care and be rewarded for doing so. And we've been pretty successful in that model, giving primary care providers the opportunity to access data and information to better manage their population and to see reductions in cost of care and utilization and improvement in quality. We've been able to expand that over time more into our larger ACO models of recent with our larger healthcare systems here, as well as our specialty episode of care programs as well. And when we've implemented these models, what we've found is they enhance care coordination, patient relationships, particularly in the area of chronic disease management, and most importantly, reward our providers for improving outcomes and value over volume. Today's panel is going to share their own perspectives and their experiences with value-based care implementation. And what we hope to get out of this discussion is learning a little bit more about the challenges, the lessons learned, the successes of implementation of value-based care, the importance of partnership, where providers, payers, policy experts, and communities can come together to advance value-based care initiatives, and any potential policy changes that might accelerate the implementation and adoption of value-based care, particularly in the commercial markets. Our panelists here today are leading experts in value-based care research, policy, and clinical implementation, and we're very lucky to have them here with us. Just a quick housekeeping note for those that are dialed in. If you want to put questions in the chat, we hope that at the end we'll have some time for Q&A, maybe from our audience who's joining us here in person as well. And with that, let me briefly introduce our guests here today. First, we have Mike Ferson. He is a senior partner at HealthScape Advisors and has spent his career helping payers and providers transform business to enhance value through partnerships, value-based payment policies, and program design. Welcome, Mike. We have Simeon Niles, who's a director of McDermott Plus, a one-stop shop for policy, lobbying, and consulting for healthcare companies. Simeon works on VBC design and population health models across Medicare, Medicaid, and commercial markets. Welcome, Simeon. And Dr. Sharon Feinstein, who is assistant professor and director of value-based programs for the Department of Medicine and Community Medicine at the University of Maryland School of Medicine. Did I get that right? Yes.
Family medicine, community medicine.
Family
yes.
medicine, right. Okay, a family medicine physician, and you have spent your career focusing on patient-centered care and are a champion of value-based care initiatives and a great partner of ours in our ACO and PCMH models as well. So thank you guys for joining us. I want to kick things off by having you guys just introduce yourselves a little bit more and talk about the work you've done and maybe add something that energizes you or excites you about value-based care. So Mike, why don't we start with you?
Sure. Well, I appreciate the opportunity to be here and look forward to the lively discussion here. As you noted, I'm a partner with HealthScape. I've been with the firm for about 13 years prior to that I was working with a firm called the Chartist Group, doing physician compensation modeling and service line development for large systems. While I've been transitioned to HealthScape, I've been really focused on payer strategy. And a lot of that has oriented around VBC transformation, from model design to alignment to kind of differentiated network products, and then shifting into enablement and how we can be supporting the provider community to actually perform better and do better and succeed under the payment models that we've been implementing. Over that time, I've seen a lot of evolution and design. I think the evolution and design will continue. I'm a big proponent of the approach that CMMI is taking in kind of continuing to push forward new innovative models that I think is pushing the industry in the right direction. I know today we're going to be talking about commercial, but I see a lot of opportunities, and what excites me is the direction that CMS is going, I think creates a lot of new avenues, right, for us to really be expanding and engaging with more providers, more different types of providers in the commercial market.
Absolutely. And what excites you? What energizes you?
I find that last part to be a little energizing.
You guys-
I'd say it's the newness. I think it's the newness.
Newness, excellent.
You know, in my opinion, from a value-based perspective, right, we've gone on a journey, and the journey has been really implementing and transforming inside payers, inside providers into foundational infrastructure and adoption. And now we're at a better platform to say, okay, where can we go? And I think the options are more variable now than they were 10 or 15 years ago. And so it will be exciting to see, the different ways in which we're going to be testing new models, engaging with new providers to achieve better results.
We'll dive into that a little bit more in this discussion as well. Thank
All
you. Simeon.
As you also mentioned, my name is Simeon Niles. I'm a director at McDermott Plus. I've been there for about 10 months now. Prior to that, I was with JP Morgan Chase, specifically a business unit there called Morgan Health, where I helped design some advanced primary care models for the bank's employees, dependents, and spouses. And then prior to that, I spent about 7 years at the CMS Innovation Center, where I wore a number of different hats, designing both service delivery as well as payment models across a number of different divisions and scopes. And what I am most excited about in value-based care is a focus on well-being. I think, when we think about health, very briefly, when I went to the Innovation Center, I went there to start the accountable health communities models, the social determinants of health model for the center, in my opinion, wildly successful. And so successful, in fact, that other models started incorporating social determinants of health. They call them health-related social needs in the government. And now we have an administration that's really focused on prevention, addressing chronic disease management, and doing that in ways that aren't always sort of traditional, for example, chronic disease management, but also looking more upstream. And so I'm really excited to see how that will be incorporated into the new slate of models.
Absolutely.
Great. Good morning, everyone. So I'm Sharon Feinstein, and as Zach said, I've been working at the University of Maryland School of Medicine in the Department of Family and Community Medicine for over 20 years. So I've seen a lot of changes from the provider perspective. I think the first time I really started focusing in on value-based care was in 2012. I was the medical director of our large practice, about 12,000 to 14,000 patients and 50 called part-time doctors. We're a residency training practice, so big practice. I was the medical director for about 6 years, and we joined the CareFirst PCMH program and kind of leaned into things like MIPS and meaningful use. And then, so I spent some time kind of thinking about those from a primary care perspective. In 2019 and most of 2020, I was the assistant medical director at the Population Health Services Organization at the University of Maryland Medical System. So it was a different perspective for me to kind of look from a larger system perspective, spend some time with some other value-based programs. But that was the time that our Maryland primary care program with the Medicare program was being stood up around the state. So I spent a lot of time in primary care practices across the state, kind of learning different ways that people did things and really supporting practices and kind of shifting sometimes for the first time to thinking differently about how they care for patients, integrating care management and other services, which was new for some practices and needed to be enhanced for other practices. So a great learning opportunity for me. And then when I came back full-time in 2020, late 2020 to my department again, I came back as the director of value-based programs. I'm still very highly clinical, but that's a piece that I've added. And it's been a journey, there, obviously I'm representing primary care space, but we're in a larger organization with specialists and the hospital system across the street. And so there's lots of different pieces that I help to work on. I think what I'm most energized by, kind of being the boots on the ground person here, is I wouldn't say that we've shifted fully to value-based care, right? We're still very much a fee-for-service world as we're trying to align everything. But what I've been excited about is being able to integrate additional services into the primary care space. So we can't be successful if the primary care provider has to do all the things and check all the boxes and figure out, how to address social determinants and, medication costs. But when you have opportunities through incentives or through shared savings to integrate other partners into your practice, like care managers, and we have pharmacists, and we have a certified diabetes educator, and we've got partners in the hospital and with our specialists. So to me, that's kind of where things should head. And these programs have given us the opportunity to start expanding the team, basically, which is quite honestly the only way we can move the needle on these quality metrics and utilization metrics is with a team and not just sort of the primary care doctor in the space and time that we have.
Yeah, that's excellent. Each of you kind of mentioned, the influence of CMS up to this point. And I think if we look back at value-based programs, the federal government, CMS, has really kind of driven that landscape. But focusing more on commercial, we know that there are unique challenges and there are some opportunities. Where do you see the commercial value-based care landscape evolving over the next few years, and what should we be looking out for? And I'll open that up to the panel to discuss. I think you each have a unique perspective on that one.
I can start.
Sure.
I'm
Yeah.
first in the row.
There you go.
It's a compelling question. As I in my intro, I talked about all the various ways in which VBC will evolve. I think one of the areas in which I see in the commercial space this progressing and evolving and playing out is that over the past 10, 15 years, many of my clients, and so my clients are the insurers or the payers across the country. We do work with nationals, we do work with a lot of blues, regional plans, across the nation here. Many times, in most instances, the value-based program, the value-based payment models have really just been seen as that payment models, where it's just we're going to align financial incentives and just let it ride. And I see that evolving. As our programs mature, as our provider network becomes more experienced in operating within the payment models, where I see from a commercial perspective is the evolution towards expanding the value proposition for high-performing providers away from just payment. And what that means is, and we can talk about this later about, what are the ways in which we kind of delineate and identify who really is high-performing in a market, which is a contentious issue. But I really do feel that, and again, this really is disproportionately on the commercial market. What we're going to see is that, payers are going to start to kind of organize more cross-functional strategies around the providers that are being successful in delivering a lot of value within their programs. And what that means is not just payment, but administrative burden relief, and also identifying ways of influencing and directing volume towards the providers that are producing the most value. And that is a missing component to really the way that in the commercial market VBC has resided today. So I think that's one piece. And the second one, and I think we're already starting to touch on this, is the engagement with a broader array of physicians, including specialists. What we are seeing is there are a lot of key conditions that are driving medical cost trend, that are driving adverse outcomes, where some of the solutions for those, whether they be on the pharmaceutical side, whether they be on the site of service for the procedural delivery, are influenced by the specialists. And in commercial with an open access network, we don't always see the tightest integration between primary care and specialty care that we would prefer. So we're seeing a lot of our clients go out and engage some of the specialists directly and get them into new types of incentive models that can incentivize certain behaviors that we're having trouble achieving right through the existing paradigm. So I think that you'll see both of those things play out kind of in parallel over the next 5 years.
So it's not just provider behavior change, it's patient member behavior
It's
change.
patient
as well,
behavior
right?
change, and I would argue it's also payer behavior change.
Payer, of course.
It's cross-functional. We need more cross-functional integration and collaboration within the four walls of our payers, which just like any organization can operate in silos.
Go ahead, please.
The only thing I would add is, and I only have the perspective of like a large employer. And I would say, you know, coming from government, we were really focused on really objective measures of success and usually claims-based. And to the extent that we understood the perspective of the provider, the patient, payer, to the extent that there was multi-payer alignment, it was sort of secondary, meaning it had to be funneled to us. And then when I went to a large employer and I brought my experience, I realized that like, and maybe not all employers are the same, but like that healthcare is a retention and recruitment tool. You know, primarily. And that large employers are now focused on value-based care as a way of constraining some of the costs. But to Mike's point, there's a real focus on some of those really high cost conditions, because there might still be some skepticism about its value across the entire like employee population. But like that to me was like a major sort of learning point for me, that like, oh, okay, you don't actually care about how they're performing on these metrics. If the employee viewpoint survey comes back and says, we love this, then you're just gonna continue paying. Got it.
Yeah, excellent perspective there. Thanks for sharing that with us. Dr. Feinstein, I mean, on the ground in the clinics with the patients, what are you seeing? I mean, we talked a little bit about specialist involvement. Are you feeling that as well as a primary care provider?
Yeah, it's sort of an interesting, again, my perspective, even though I do work with other primary care providers within our system that are different than mine, we are part of a larger network that also has specialty providers. And as a primary care provider, we just rely on those partnerships, right? Like we can't, you know, not that a primary care doctor, we manage congestive heart failure and uncontrolled diabetes and COPD, like kind of big things that drive people into the hospital and utilization. But we need our specialists, right? Like we, if someone has very uncontrolled CHF, like I want to partner with our cardiologist. I want to be partnering with our pulmonologist. And we have that already kind of built in some ways, but it's been interesting for me to see our evolution now moving from the patient-centered medical home model to the ACO, which we just started this year in our organization, and sort of what that's meant, like how that's shifted. Two things it shifted. It's one, it's sort of engaging more with the primary care, the specialty providers around value-based care, which I just don't think was as much on the radar for people, even though a lot of the cost is associated with everyone, including the specialists. So it shifted there, but I'm quite honestly using it as an opportunity to also elevate the voice of primary care within our system. Our specialists are learning more about what we do and what we provide, which I think is also really, really helpful. So that's exciting for me. And I hope that that shift will lead to more success for our patients and those partnerships. And I know that'll be different in community practices where those partnerships aren't as like already aligned, right? Like we're a system, so we have these aligned partnerships, but I think there's a lot of value in that. And I think those relationships can actually be different and sometimes better because primary care driving business to our specialists is important too. We'll probably get into it later, but we've had some very targeted initiatives that have been successful that I'm excited about, because again, it kind of creates these partnerships outside of the primary care network, and being able to have a patient know that there's partnerships, and that, you know, if there's an exacerbation, they might call my practice, but I might be, you know, I might not be able to see me, but like, I'm gonna message their heart doctor, which I've done before, and said, hey, let's collaborate on this care. And when they're being brought into the ACO model and kind of being part of that and learning about a new model of care around value-based care, sort of shifts the energy a little bit. And it sort of shifts the energy towards also emphasizing the importance of primary care, right? Like, I feel like that's been an interesting journey over the past 2 years, is like really a lot of folks really understanding how important and valuable and critical the primary care space is.
Absolutely necessary, I think, in driving that. And we will get into some of those success stories. I think we're all excited to hear kind of like what's working on the ground, especially at the patient level or the member level. But I was thinking about, you know, this discussion, and we kind of started it off by talking about where we were being pushed, you know, from the federal landscape to the commercial side of things. And you know, we're hearing more and more about, you know, the evolution. I think, Simeon, you wrote about this recently, the government kind of putting it out there that we need to move more towards value as opposed to just quality improvement. So when we think about the commercial space, maybe some of the work that you've done across all lines of business, focusing on addressing total cost of care, who's doing that well? Are there any lessons that we could learn from other organizations or other programs that have, you know, dove into the cost of care space when it comes to value, and not just a focus on HEDIS measures?
You went to the really tough question very quickly.
If not, maybe that is an area that we still have a lot of learning, but, you know, what do we need to do?
Yeah.
To kind of build up that area and
That went to
really
you,
focus on.
I know.
And Mike will ask you the same thing.
Yeah.
Your answer.
I was like, maybe both of them have better responses. I can kick this one off too. And speaking more specifically, maybe to the innovation center's models, and the past directors have spoken publicly about this and their perspective on the success of the center, and particularly certain directors believing that the agency really, or the center really hasn't achieved its statutory mission, right? The statutory mission of the Innovation Center is to improve it's complicated, but it's like improve quality while keeping costs the same, decrease costs while keeping quality the same, or improve quality and decrease costs at the same time. That seems like impossible, right? He's like, I want more for less money. And that's just a really hard thing to accomplish. I think the things that the center has done really well are in sort of the service delivery area, where you can see really great outcomes, you know, on the ground, providers are satisfied, et cetera. I think the cost containment part of that is where, you know, the center has not really been as successful, because they're looking for significant reductions while also increasing the number of services that beneficiaries receive. This is me, Simeon, speaking as Simeon. I would challenge us to sort of reorient sort of what cost containment looks like. For example, there was the Vermont ACO model that did not reduce costs, but it bent the cost curve, right? Like what they were projecting costs would be, it was able to decrease that. Costs still increased year over year, just not by as much as it would have been in the absence of the model. I think that I would consider that successful, right? I think we just think of ways in a system where value-based care models don't operate in a silo. They operate there's sort of this island of value-based care in a sea of fee-for-service. And there's so many other access points for beneficiaries, particularly if you're in fee-for-service, you can go anywhere, that we need to think, I believe we need to think a bit more about what does cost containment look like.
And I think bending the cost curve
Yes.
is an admirable goal at this point, right? To decrease the rise in cost of cares. And I would call that success as well. Mike, are you seeing other Blues or other clients that you work with really implementing cost of care models that focus on containing healthcare costs?
I mean, so I'm nodding vociferously over the points Simeon's making here. You asked the question, who's doing it? From my perspective, the kind of gold standard continues to be a Kaiser, right? That has, a closed system, that has an HMO model, that like promotes primary care, has aligned incentives all the way across the board, right? That continues to produce really high patient satisfaction, high quality at reduced cost. The challenge has always been, it is very difficult to replicate that model elsewhere, particularly in the commercial market. I continue to be, and that is in part because of the structural challenges that exist, with employer-sponsored insurance, particularly in an environment when employers are preferring open access PPO products in which it's very difficult to cultivate and the patient primary care relationship. It can be very difficult to understand who the primary care provider is that is seeing the patient, so on and so forth. Which is why there's a lot of fighting the good fight, right, within the PPO environment, but I continue to be a huge proponent of the HMO model structure from a product design. And what I have seen is the HMO has gone back and forth, right, in its history. I have seen some clients, and I'll use one, Blue in particular, Blue Cross of Illinois, where they have set up an HMO product line that has all the standard hallmarks. So when you enroll, you select the primary care. It's very transparent, and they have been able to they've had that in the market for 20, 30 years. And what that has allowed them to do is to build specialized infrastructure internally, but also to engage with their medical groups that have been participating in their HMO product for 20 years in a different way. And that has allowed the physician groups to develop specialized infrastructure. And it has created this ecosystem that is not maybe Kaiser, but it is a material advancement from what I see in most PPO environments. And so I do think it's a strategic question that our insurers can ask themselves, and it does come down to employer receptivity. But if there are ways in which we can revitalize HMO product designs, and then use that as a platform for achieving better engagement with the primary care, allowing the primary care to truly be the quarterback and care coordinator for that patient, I think that would be a material advancement. It's just going to take a lot of hard work to get the employer community to be more receptive to those types of products.
Yeah, and that doesn't happen overnight. That takes time.
It's a multi-year journey for my client to get there, and for any other client to do the same.
Dr. Feinstein, thinking about how we communicate value to residents, for example, in your clinic, how are we teaching young physicians the mix of value without maybe sacrificing patient care? How do we make sure that we keep outcomes high, we keep quality high, patient experience high, but also in a way that leads to affordability?
Yeah, it's an interesting question. So part of what I love about being at the University of Maryland and why I've been there for so long is that opportunity to teach, right? Like, we're a teaching institute. We have 30 residents every year and 10 new residents that sort of join. We have a 3-year program. And so part of, honestly, my role there is to talk about these, not just value-based care programs, but I do a lot of work on patient experience in general with our residents, because they're like the future primary care providers. Most of them stay in the state of Maryland. So we're trying to increase the primary care, cohort that have this background. And so it's an interesting question that you ask around, how do we teach these new learners while they're infusing so much information? And I actually think it's really critical, right? Because if the primary care doctors who are leaving and joining the workforce understand that they're walking into these new, almost like a new landscape than from when I walked in, right? This is very different when I started practicing over 20 years ago. They may be incentivized differently, which is fine. But most of us as primary care doctors, our whole focus is on the care of the patient, right? So what I try to do when I'm teaching about these programs is not just the what, because the what can get overwhelming. The what can be, what do I have to focus on now? And what do I, what's that button I have to click? And wait a second, I don't have the resources I need for this patient and I don't know what to do with that patient. I focus a lot more on the why. So when we talk to our residents about the why we're doing it, which could be lots of things, right? Sometimes the why is, you know, when we engage in these programs, we have more services that are available to our patients. When we engage in programs, we have the revenue in order to hire another nurse care manager or a social worker or expand, like we're expanding our pharmacy, our embedded pharmacist services, which has been critical for our patient population. And so we may be able to hire another medical assistant. I know it sounds like, but it's very granular. It's like, it's not just about clicking the button and about, you know, obviously we want their diabetes and their hypertension and the quality measures. We want to keep our patients out of the hospital. Like the why is in sometimes very clear, but when you get down to, well, what is CareFirst role, right? What is, you know, Medicare's role? What are all these programs? It's sort of going, what will this mean for your patient? What will this mean for your practice? What will this mean for you? Kind of that why I think helps. And that's what I try to focus on. And honestly, the truth is I also have to focus on the what, right? Like these are all the specific things, which can actually get really complicated because we have so many different programs that have so many different resources and so many different measures. So I think it's easy for residents and providers to say, we want to keep our patients out of the hospital, right? We don't want to keep them from going to the hospital when they need to, but we need to set up services so that they don't go to the hospital because they ran out of medicine, or they don't go to the hospital because they didn't know how to manage their heart failure, or they thought that going to the ER made more sense than calling their heart doctor. We need to set up services so that they can have opportunities outside of that. So I think when I teach them, I'm trying to have them think again about the why, but honestly say, this is the reality of your landscape that you're walking into. So you have to learn this stuff. You have to understand the value so that you know how to kind of use that within your own practices, right? Like this knowledge you need to have when you walk out the doors. So I think it's been pretty well received. I think sometimes it's overwhelming, but I think it's been pretty well received.
Yeah,
Yeah.
overwhelming. Administrative burden is something we talk about a lot, right? You just mentioned 9 different programs.
Yes.
So how do we balance that, right? And what can we be doing to partner to
Yeah.
reduce some of that administrative burden on those that we rely on to deliver care?
Yeah. The administrative burden is tough because as I think it's been clear, like I wear lots of hats in the department, but I wear 2 major hats in this space, right? I wear probably 3 major hats. One is just as a primary care provider, which I think is really helpful because I'm walking the walk and talking the talk, right? Like I'm caring for the same patients. I am teaching, so there's that extra piece, right? So I see a lot of patients just with residents and I'm teaching them. But then I do a lot of the administrative work. And I'm a data person. I have an engineering background. And so data, I know people don't love data, but I'm a data person and I like getting into the weeds sometimes to really understand it. And so I'm kind of wearing both of those hats and I do a lot of the administrative stuff. And it's too much, right? It's a lot. I think the things that have helped from a practice perspective is the programs that have coaches, right? So I would meet once a month with our CareFirst coach. You know, we've had a few different coaches over the years, but to me that was really invaluable because I just can't keep track of all the things and all the pieces. And I really appreciated those month check-ins to say, here's what the data is looking like. You know, I appreciated being able to go into the databases and kind of play with it myself a little bit and understand where we were and pull down attributed members that were missing certain, quality metrics, or we're going to the hospital a lot and kind of focusing in on those patients. So I think the administrative burden is lessened a little bit by having those partners with CareFirst, with some of the other programs we're having. And I think maybe a little bit more of that, figuring out how we build also more teams, even within the practice themselves, having as many people as possible kind of understand these programs. And in my particular instance, thinking about how our larger system can really help. So we have not just family medicine, but our other large primary care providers, our internal medicine practice. And now with some shift in moving to the ACO model, we'll be engaging more pediatric practices. And so administrative burden, in my opinion, goes now we're all working on this, right? And I have partners in each of those departments. We work together because we're supporting each other. But I think that will also help administrative burden is when we start thinking about all of those people need the same resources and support, and how do we partner even within our own large system to think more across instead of just in silos. Yeah. So administrative burden though is I don't have a solution. It's a lot.
Yeah,
It's a lot.
definitely. And Mike and Simeon, how do we approach administrative burden, maybe even beyond that, just more ready adoption of VBC from a policy landscape? What are some things that we could be focusing on, which our policymakers know about this?
I'll start this one. Please. I think a couple of things come to mind. First and foremost, Dr. Feinstein touched on metrics, and I do think that there's some low hanging fruit. Our payer clients, the payer community at large, I think could really improve the way it collaborates with each other in the structure of value-based models, and particularly when it comes down to things like quality metrics, right? That, we do not want to be contributing to the problem of asking our primary care physicians, one of 6 private payers, right, to be, reporting out and measuring the quality performance for just that slice of their population. It just doesn't make sense. So I think that quality measurement, right, is an area in which the payer community needs to kind of collaborate a little bit more, both from a metric selection, but also from a measurement perspective. So you're not trying to necessarily measure each slice, right, of the primary care panel. And then I'm interested in, the industry shift around prior authorization, and how I think the industry is being more intentional, right, about enabling greater levels of efficiency within that very burdensome, very kind of abrasive process. That's going to mean, in my opinion, increasing the speed and the integration of prior authorizations, making it more automatic, but also, I referenced high performing providers, and, we are pushing our clients to consider more gold coding programs, right? So that, for the physicians that are demonstrating success, we can be alleviating some of the prior authorization requirements as a first step towards getting more, creating more of a value proposition to them, or in fact being high performing through administrative burden reduction.
Sure. Simeon, what are your thoughts there?
One, I want to echo Mike's comments around sort of quality measurement, and I feel like that's actually a really good place for government to really partner with industry in ways that is done in other examples, to really come to a consensus around sort of what's important. I'm thinking about sort of the prior administration's move towards digital quality measures, which will probably continue. And a lot of our clients have been saying like, hey, this is too much. Hey, we can't do this in this timeline. I don't think the government understands the amount of money it will cost to update systems in a year, 2 years, like it'll blow budgets. And I think that that's an opportunity where everyone can win, right? The government can get what it wants in terms of reporting. There'll be full alignment if everyone's brought to the table with all the payers, and it will reduce burden on providers because there's maybe hopefully one dashboard instead of multiple tabs. It looks like my computer. I have like 20 tabs as my to-do list. And then everyone wins in that way. And I think, this administration has signaled their willingness, openness to collaborate with industry. And so I really hope that that is sincere and that we can see some partnership around that type of reporting. I think, the prior administration was moving towards the universal measurements, but they were still selecting the measures. And then they were saying, well, we're Medicare, so you have to follow suit. And I think this is a really good opportunity for greater collaboration.
Yeah, I wanted to add, I think that I love this discussion on alignment because, again, when you're the person who's reviewing all the data and looking at all the different dashboards, it's partly the administrative burden of reporting, running the metrics, understanding, figuring out which patients to reach out to. But it's also, it dilutes a little bit the why, when you're talking to providers, because there's so many different things to focus on. Just recently, because we've added some value-based programs that we're looking at, I just had to take all of them and put them on a big spreadsheet and try to align the metrics myself, right? Like I did the spreadsheet allows me to kind of filter and sort and pivot and go like, where are the things, and it kind of has all of our results on it, right? Like, where are we with our, and that takes a lot of time, and I'm partnering with other folks in the organization to help me with that. But it's sort of the first time I've been able to go, okay, where should we be spending our energy, right? What actually, let's choose a metric, and resources, right? It's all about resources sometimes in primary care, like where do we spend our dollars? What's going to have the biggest bang for the buck? So I think for me, alignment among these different programs is key. And even like a simple example, I know it sounds crazy, but the measure for diabetes for CareFirst, for instance, is different than the measure for Medicare, like the goal. It's, less than 9 A1C versus less than 8. And it's these simple things are interesting. But it just shifts like that extra, just that one difference makes like, we could be doing really great in one area. And for CareFirst, it's just the CareFirst patients, but for the Medicare programs, it's the entire panel of patients that you see across everyone. It's your electronic quality measure. And so that simple thing is like, that just puts a wrench in things when you start thinking about programs and which patients to reach out to and where to spend your dollars. So I think alignment is kind of one of the biggest things. Alignment and centralized databases would be from a practice standpoint would be huge. Yeah.
The other thing I might add is I think on June 16th, and a request for information closed from CMS where they were asking a lot of these same questions around like what can the agency do, how the agency can use technology to reduce burden, not just for the agency, but also providers. And so, I mean, time has passed, but there's still an opportunity to provide comments, even though it's not the time for the RFI is closed. And like, that's a real opportunity to make your voice heard. It seems like the agency is really interested in this particular topic, whether it is something that technology alone can solve, or it needs technology, a change in requirements process. Legal requirements is another story, but the agency is open to that.
Beyond technology, what else can speed up alignment and maybe bring folks to the table quicker and increase the adoption of the conversation and the infrastructure to align?
I mean, I just go back to my first point. You have to be willing to have that conversation. And I don't imagine it's terribly hard, right? We just had a number of different plans sign on to limiting or the cost of their drugs, right? That was negotiation between those plans and the government. It's voluntary. I imagine you could also have another conversation around sort of what alignment might look like. I think you just have to be willing to walk into the room and not leave until there's some consensus.
Mm-hmm. Sure, absolutely. I'm going to shift a little bit. Mike, you've done a lot of work with national clients, a lot of different types of value-based programs and payment reform. Tell us a little bit about the role of risk sharing when it comes to payments. How does shared savings, two-sided risk, capitation, how does that play into the provider incentive model? What are some things that we should be looking towards in the next year or two?
It's been a little bit of a journey. If you were to ask me this question 5 to 7 years ago, I would point to a lot of my clients had board approved and level goals around shifting to risk. That was the definition of success. By any and all means, just shift to risk. A lot of us probably have seen the representation of value-based payment models on a continuum. And so it was just go right. And I think we need to moderate that expectation a little bit. And I think a lot of our clients have kind of modified their goals in that direction. One of the, in part, right, what are we trying to achieve as a payer when we move into a two-sided risk? Because there's two options to answer that question. One would be we're trying to achieve we're outsourcing our actuarial risk to ensure our products are priced appropriately, right? But then the other one is to align incentives, to ensure that there are financial incentives that are able to support and also ensure alignment with some transformation that we want to occur. And to me, that should be the goal moving forward. I'm not a proponent, and it particularly because a lot of the challenges that we've already talked about in the commercial market of placing providers under enormous downside risk when they really lack some of the fundamental controls, right, in order to appropriately manage said risk. But I continue to be a proponent of making sure that there are incentive dollars available to providers to fund the transition and to continue to operate practices that are doing additional things, right, in order to create what we define as value. So, you know, one of the ways in which I've seen this evolve is, and I think this is a net positive, it used to be, you know, from a pure kind of contracting perspective, we had our fee for value contractors and our fee for service contractors. You know, we had discussions between plans and providers that were just on the fee schedule. Well, let's lock down all of the things there. And oh, by the way, there's this separate conversation that we'll have, you know, in a couple of months or even next year with a totally different set of stakeholders, right, talking about the value base. And what I have seen is bringing that together. And I do believe that that's a net positive because I think it helps everybody to kind of appreciate the full financial picture, right, of a contractual relationship between a payer and provider. But it also gives us opportunities to be moderating the fee schedule and moderating the value through value-based contracts in a coordinated way. And that could be another way of aligning incentives without kind of requiring physicians to sign up for this model where in 18 months, you might be requesting a $5 million payment because guess what? You know, you went over budget, but we just told you about that 3 months ago.
Right.
I think that's the situation we need to avoid. So bringing together some of the contracting pieces, I think is actually helpful, create more flexibility. And in my mind, it's all about sustainability. How do we create these financial arrangements that have sustainability to them? If you put too much risk in an environment where physicians are not able to manage it, what are you going to see? You're just going to see, you know, your provider organizations decide to opt out of the model, and then you've lost a lot of the momentum that you've jointly tried to create over the past several years.
Sure. Absolutely. Dr. Feinstein, risk aside even, do the financial incentives today, are they aligning to create behavior change with providers? And if not, what can we be doing to move the needle on those incentive models to actually drive the change we're looking for?
Yeah, so I'm in a kind of an interesting position to answer that question because of the way my practice operates, that we're a large organization of part-time providers and a residency practice, we don't have any specific direct provider incentives, right? Like that's just not something that we've been able to do. I know that happens in other University of Maryland medical system practices that are not part of the School of Medicine. And I think that that's, you know, driven some change, right? Because dollars and cents, if you're working hard, like definitely puts a little bit extra in that why column, right? A little of that personal why, like, you know, if I'm doing well. And the truth is that also places very specific data for that provider. So sometimes there's a little bit of a, you know, like, I need to be doing better in these areas for my patients, or I didn't realize, you know, so a little more attention on providers that aren't doing as well. So maybe some more resources are put there. But in my practice, the providers don't see any direct incentives for any of these programs. What they see is now we have these resources in the practice for our patients that we didn't have before. And I actually think that's really powerful. Because of the way we operate, it's a little hard to say, like to connect the dots from A to B to C to say it's because we're engaged with this program. But I do a little of that, right? It's, you know, we have these resources because we're engaged with this program. And I think that helps to drive change. But the direct incentive dollars to our providers doesn't quite happen in that way in my practice. So it's a little hard to know what might drive that. I definitely think some colleagues of mine might be able to figure out, you know, how that does things. But like you said, one of you guys said before, unless there's true change in the practice and not just sort of piling more and more things in the 15 minutes I have during my visit, I feel like that's where providers want to see change, right? So that's incentive in a different way, but it's let me get another person, let me get a community health worker, let's embed some other resources. I feel like most of us, like that's what we care about is how do we better take care of our patients and don't feel like if it's just me that doesn't have the time, it's not going to get done, or if it's not me that knows the resource in the community that'll help the patient. So I guess it's a different kind of incentive, and I think that drives change too.
Mm-hmm. Yeah. Simeon, anything to add there on how we can build that alignment, create those financial incentives, and drive that change that we're looking for from the provider community?
I have nothing to add. Well, fantastic.
Perfect. Okay. Well, then this is a great time for us to pause for a moment and see if we've got any questions from our audience, either here or on the Zoom link.
Quick question. We haven't talked about pharmacy yet. Do you have thoughts on how we incorporate pharmacy into value-based care?
Oh, boy.
Thought I had tough.
I know. Yeah, this continues to be the simple answer, in my opinion, right? For speaking from the payer perspective, right, is the more integration that you have, with medical and pharmacy benefits, the better able you will be able to integrate those into your value-based models. I think the major challenge that I've seen from clients is that it's particularly with a large portion of self-insured business, they have pharmacy benefits through some other provider. And so therefore it becomes almost impossible to measure the performance that we're seeing on the pharmacy side, and it takes up a huge portion of our attributed population. So the simple answer, I think, is increasing PBM, integration with medical and pharmacy benefits is the first step to enable, inclusion of pharmacy more routinely into the program. But I also think that we need to be thinking very judiciously about the impact of pharmacy on cost trends. Again, one of the big problems in the commercial market is you really have to be setting your cost targets based on medical costs. There you can't be, in many of those segments, you can't be basing it on revenue base. And the cost trend on pharmacy is kind of out of control, which is why we want to in part include it, but it also creates, I think, a lot of noise and a lot of issues for the providers in terms of like what really is the appropriate target or definition of success given some of the out of control trending that we've seen. So I'm not giving you a great answer, but I think that it's part of the future, but those two major challenges kind of need to be addressed systematically in order for us, I think, to really bring incentives in alignment on both the medical and the pharmacy side.
Other questions from our in-person audience or virtual audience?
So we have a couple questions from the virtual audience. First one on behavioral health. So what are the impacts of value-based care on behavioral health? And then I'll take a little bit of liberty and add a second part to it. Can you talk a little bit about how we can effectively integrate behavioral health providers into these models so that they're both empowered as well as accountable for managing the total health of these patients?
Who wants to take that one?
Yeah, I mean, I don't, again, I know Simeon and Mike can kind of speak from the larger model, but I'm really glad actually that someone brought up behavioral health because especially working in Baltimore City, but any communities really is behavioral health is, I talk about it all the time when I'm in meetings, right? Like that's the one area where my practice is still kind of looking to find resources. And it's one of the things that we find impacts our patients so significantly, right? Like even, depression can keep someone from taking their medications or engaging in, changes to their general health care that would be helpful for them, right? So, and I think it's actually interestingly a space where we haven't fully aligned our value-based programs with behavioral health. So even when you look at the metrics, there's not a lot of behavioral health metrics. There may be, a depression screen here and there, which by the way, has actually changed the way we've done things in our practice, right? Like we thought very much about how we integrate even just screening on behavioral health, both mental health, but also addictions, and doing it more systematically, driven a little bit by metrics, driven a lot by kind of needs in our community. But to me, it's like critical and important. So I think the other interesting thing for me is that, a lot of our commercial payers, including CareFirst, will say we have resources for patients who need mental health services, which is helpful and not integrated, right? So when you have a patient population that finds it really hard, like prefers everything to be in the walls of their space where they are. When we've had behavioralists in our practice, to me, it's addressed our behavioral health need a lot more. I'm not suggesting that we should add a bunch of metrics for behavioral, things, but thinking about how we infuse either more dollars, more incentive, more upfront dollars in order to be able to integrate some of these services, honestly, into the primary care space. Either you have a partner that's really close, but my pie in the sky for my practice would be to have at least one full-time behavioralist that we could maybe pilot by having dollars and cents upfront. Again, with all these not aligned, we'd have to kind of pull dollars from different places, which we've tried. But that's one. I mean, really like figuring out the best way to, I mean, again, putting it in the primary care space makes everything one-stop shop, which to me will have the biggest impact on patients who need care. Like it just, my patients prefer to just know someone who's on my team, and for me to be able to talk with the behavioralist or the pharmacist or the diabetes educator, how that would integrate to the larger system, you know, what services we can provide. I'm not quite sure where that lands. I'll look to my other colleagues here to think about how that would look like from the model standpoint, but the need is huge.
Making care
The need
convenient.
is huge.
Right.
What you said,
So
yeah,
making
making
care
care
convenient.
convenient, right, yeah. Or even like, we're looking at hopefully integrating like a collaborative care model, which is sort of a triangle model with sort of a psychiatry team and a embedded behavioralist. And but those aren't also easy to stand up all the time. But to me, that would be the most ideal. Yeah.
The only thing I might add is 100% agree, measurement, because I looked at this when I was at JP Morgan as a place to explore. They also have an investment arm, so I collaborated with my colleagues on the ventures team to figure out if there was some solution to this, right? Collaborative care model is the most successful behavioral health integration model out there. It's also very expensive. And like the rest of healthcare, there's a capacity issue.
Yeah.
We looked at, some other models that sort of dealt more with like anxiety, depression, because that's generally what's most prevalent in sort of, an employed population. And even that was challenging. And the only way to sort of overcome the capacity issue was to pay more to have dedicated staff, right? Like, and so the solution to some of the problems was increasing the amount of expenditures, the amount of payments you had to make, which at some point just becomes completely unsustainable.
Yeah.
And so then we also looked at, well, are there other interventions that you could use, right? Like there are text messaging solutions that have some evidence behind them. There are AI tools that have some evidence behind them. I think another challenge with a lot of the tools and startups that we looked at was there just wasn't enough evidence to say, let's make a huge bet on this particular tool. But I'm hoping, given everyone's particular excitement about AI, that we can actually come away with something that can actually solve a huge problem for us.
Yeah, I was gonna add, I think, kind of in thinking about this even more is, when we were talking about kind of embedded folks, I wanted to just sort of throw out there that this is another space in which primary care, we need sort of even more understanding across, systems, because I manage depression, I manage anxiety. Like I'm capable of doing those things where what I'm not is a therapist, right? I'm not a behavioralist. And even though I play that role for some of my patients sometimes because of our relationship over years, I feel like that's where we could also think about cost models, right? Like I don't need to send someone to a psychiatrist specialist when I will need to if they have schizophrenia or they have, depression that I'm not able to manage, in my tools. But if I had a partner within my practice, that's within my scope, but I can't do everything. And so that reduces specialty costs, that reduces someone going outside of the system as well, if we really think about integrated systems. And the collaborative care model is sort of like a piece of that, the behavioralist embedded in the primary care practice with a psychiatrist that doesn't see the patient, but then informs and educates the primary care doctor. To me, that's a beautiful model. But there's also that other simple model, which is, figure out a way to get behavioralists into each of these practices for the primary care doctor to manage what they can and also have those resources for their patients. To me, again, I'm not the dollars and cents person in the larger sense, but I feel like that also helps reduce costs. Everything's there. And then I'm addressing their depression while I'm addressing their hypertension. That's one visit, one spot, one place. And oftentimes these things are like this, they're very integrated.
Yeah, fantastic. There are a bunch more questions I wish I could ask right now, but I do have to wrap us up. Just thinking about, the discussion today, and I just want to thank you guys. I mean, the depth of these answers and the thoughtfulness and the responses, I think was kind of spot on with what we needed to hear and what our audience should be listening to as we think about advancing value-based care. A couple things stood out to me. cross-functional collaboration, that was kind of key in what you guys were talking about, and the need for payers, for providers, even on the specialists to be brought in, right? Everyone has to participate in order for this to work, at federal, state, local levels, and commercial and government as well. And then the support, right? We need support, providers need support, payers need support, in order to make care convenient, to make things easier. It's not gonna happen overnight. Coming together will really help advance this over time. So when we bring you guys back in a few years, we'll talk about what's changed from now to that point here, those success stories. But I want to thank you guys again. We really appreciate you joining us today. I want to thank our audience, both in person and over the Skype, the Skype link. This is the type of conversation we need to advance value-based care. And we look forward to seeing where things go in the future. Please stick around if anyone has questions or want to chat, but we hope everyone has a wonderful day. And thanks for attending.